Today we are going to discuss on men's health. In particular, we are going to discuss about the prostate cancer, its physical and mental effect on the patient, the modes of treatment that are available, as well as the support system for the patient. Welcome everyone. So my name is Mukaminganga. I'm a sorry about that. My name is Mukaminganga. I'm a patient support specialist at My Health Africa. So My Health Africa is a full service platform that has changed the way patients access specialized medical treatment through partnering up with facilities and doctors regionally. We have facilities in South Africa, we have Egypt, we have Nigeria, we have Tanzania, Uganda, and of course we have specialists here in Kenya as well. We also incorporate international medical treatment that is part of My Health Africa group. The international medical treatment has helped patients who are seeking medical treatment overseas by partnering up with our medical partners, such as the Birmingham International Hospital in Thailand. We have the Apollo Hospital in India. We have the American Hospital Dubai, just to mention a few. So on today's session, we have specialists that are going to guide us around men's health. We have Dr. Eric Mutiso. He's a general surgeon as well as a urologist with over 10 years of experience in the field, some of which he has been in the military. We have Dr. Robert Mutengo. Dr. Robert works with HCG Cancer Center. The HCG Cancer Center is the first private comprehensive care center in East Africa. They do treatment for cancer. Some of the treatments include surgical oncology, there's radiation, among others. So, and we also have Mr. Elias Gikundi. Mr. Elias Gikundi is a counseling psychologist at the Kenya Association of Professional Counselors. He's also the co-founder as well as the executive director at KFDC. So maybe Dr. Eric Mutiso, you can start us off with a bit more introduction of yourself.
Hello. I'm sorry for the darkness. This is the only lightest place I could get.
That's
yes.
Okay.
As you said, my name is Dr. Eric Mutiso. I'm a general surgeon, also specialized in urology. We have been working here in Nairobi and also work in Garissa County as well as Machakos County. So this is usually our area of expertise, and we work with others, as you said. Thank you very much.
Thank you so much, Dr. Mutiso, for that. Dr. Robert, kindly maybe tell us a little bit about yourself as well.
Good evening, everyone. My name is Dr. Robert Mutengo. I'm a cancer specialist. I'm based at Cancer Care Kenya, Parklands, Nairobi. I majorly treat solid tumors with a key interest in GI malignancies and research. Thank you.
Thank you so much for that. We appreciate. Mr. Elliot, kindly tell our audiences a little bit about you as well.
I'm Elias Gikundi, and I'm a counseling psychologist working with the Kenya Association of Professional Counselors here in Nairobi, as well as the current chairperson for counselors and psychologists in Kenya through the Kenya Counseling and Psychological Association. I am a practicing counselor, even though a lot of my time now I spend in also management issues in the counseling programs. Thank you.
Thank you so much for that. As we start this webinar, we said our focus is mainly on prostate cancer. So I'd like maybe Dr. Robert Mutengo to let us know what exactly is prostate cancer. Dr. Mutengo, can you hear us? Sorry.
Yes, I can hear you.
Yes, so kindly maybe let us know what exactly is prostate cancer?
Can I upload my slides?
Yes, kindly.
All right, so as I said earlier, I work at Cancer Center, Nairobi, Parklands. I'm a cancer specialist, and we treat all kind of tumors, and that's my area of interest. So today I've made a simple presentation on prostate cancer. It's quite simple, and I'm sure all of us will understand and enjoy. So I want to start by, first of all, introducing what prostate is. It's interesting to note that many males do not really understand what the prostate is and what it does. So the prostate is part of the male reproductive system. It is located just between the bladder and the rectum. And the primary function is to produce seminal fluid that nourishes and transports semen. You will see, as depicted in the picture here, that the prostate is just below the urinary bladder above and the rectum. There are basically four major organs, four main components of the male reproductive system. That is the penis, the testes, and the prostate, and the seminal vesicles right there. So again, as part of introduction, cancer is a disease caused by abnormal cell division and replication. It infiltrates and destroys other body tissues, and also has the ability to spread to other parts of the body. It is the second leading cause of death worldwide after cardiovascular diseases. All right, so when we narrow down to prostate cancer, basically prostate cancer is an abnormal proliferation of the prostate cells. It is the #1 cancer in males, and 1 out of 7 men will be diagnosed with prostate cancer by the age of 66. It is the #2 cause of death after lung cancer. So overall, worldwide, lung cancer is the #1. But when we talk about males, prostate is leading. It is more aggressive in Blacks and African Americans. All right, so risk factors for developing prostate cancer include increasing in age, like I said earlier. Men above 66 years are more prone to developing disease. African ancestry, Blacks, Africans have been shown to develop disease more frequently than Caucasians, and also genetic mutations, like the ones indicated here, BRCA1 and BRCA2 mutations. These individuals are more at risk of having prostate cancer. Also, family history. If someone has their father or brother who has had prostate cancer, they have a 10% chance of developing cancer themselves. And again, lifestyle factors also, like diet, smoking, and lack of exercise, which results in obesity and overweight. These also results in, put the person at risk for developing prostate cancer. So symptoms of prostate cancer, usually it is asymptomatic. Majority of the patients are identified or diagnosed or screened after having a suspicious PSA or incidental finding on TAP. TAP means transurethral resection of the prostate. So this person will usually be asymptomatic for several years. Then they'll just decide to go to run a PSA test, and then it is found to be high. Then upon further investigations, they are found to have prostate cancer. Or sometimes a person may go to see the urologist for other reasons, which are not even cancer related, but upon biopsy of the prostate, it is found to be cancerous. Another also a way of picking it is by having a DRE examination. DRE meaning digital rectal examination. You can see from the picture right here, the prostate can be easily accessed from the anus. So the doctor, by inserting their finger, they're able to feel the prostate. They feel the nodularity, or if it is hard or soft or indurated, depending on how they will feel it, it will raise their suspicion for cancer. And so upon further investigations, that also may confirm the diagnosis. Note here that majority of these patients are usually asymptomatic. They have nothing to point that cancer is developing in them. So also, sometimes patients come with advanced disease. Locally advanced disease may present with obstructive urinary symptoms. The patient may notice that their urine stream is weak or poor, or they are going to the washroom frequently, or they have dysuria, discomfort when passing urine, or sometimes they may even be blood. So those also are pointing something could be wrong with the prostate. And also a patient may come and they have pain, complaint of back pain or shoulder or hip, pain. And upon further investigations, we realize that the person is having actually stage 4 disease, whereby the cancer has spread to the bones. As you can see on the image here depicted, the black patches indicate disease. So this person has been asymptomatic, meaning they have been well without any symptoms suggesting disease is going on. But at some point they develop back pain, which does not respond to painkillers. So they decide to go to see a doctor, and upon investigations, they are found to have stage 4 disease. All this while they have been without any symptoms. So,
Dr. before we get into screening, maybe I can just have a quick question for Dr. Mutiso, seeing as you have said that usually the diagnosis is made by urologists. I'd like to hear from him. When patients come in seeking diagnosis or seeking other, what is the process? How does Dr. Mutiso take them through the process? The signs that he looks out for? Dr. Mutiso, maybe enlighten us on that from when the patient comes into your clinic.
Okay. I think the video will not be of use now. Maybe you cannot see me. So, can you hear me?
Yes, we can hear you.
Okay, yes. For usually in our practice, especially in our region, most of the patients would usually come with symptoms of obstruction. That is, their urine is not coming out well, they're having pain when they're urinating, or they might be seeing other things in their urine like blood, or it can be infected. So once we get these patients, most of them are usually above 50 years, which is usually the normal range of this condition. We have to take them through a process of first diagnosis. To get a diagnosis, we examine the patient. As you heard from Dr. we start with examining the prostate. We do the digital rectal examination, and eventually would go to do imaging studies, which usually is the ultrasound or the CT scan. This one, and then there is a laboratory where we test what Dr. mentioned, the PSA, which is a protein that is made in the prostate that is specific to the prostate and is usually raised in cases of cancer. So with these three, we can make a relative impression of that we have prostate cancer, and to confirm it, we have to do a procedure called a prostate biopsy. In such a situation, we usually use a specialized needle to get small strips of the prostate, which are then taken to our colleagues in the laboratory, who confirm for us that there is or there is no cancer. Yes.
Okay, thank you so much for that. Maybe just to ask another question on that, do you find that patients who are coming in for the test or for just checkup, do you find it that they come in a little bit too late, or did they come in early? What is your view on that?
Yes, in our experience, which is I believe the experience of most of our colleagues, majority of the patients always come in at late stage visits. This is due to the fact that, as has been mentioned, that it is usually there are no symptoms in the early stages. So most of our patients will either end up in stage 3 or stage 4 cancer, where already it has spread. So that is our experience in our region.
Okay, thank you so much for that. Maybe kindly just to inquire from Mr. Gikundi, you see, we find out that men don't usually come out to talk about their health issues. Maybe psychologically speaking, can you maybe let us know what can be done to encourage men to go for checkups, regular checkups?
Thank you, Hip, and thank you, Robert, for that. No, Alec, for that presentation. And I will not delve into the science of the cancer, the prostate cancer, at all. I'll delve into the psychological side of issues to do with men's health, and specifically mental health, their mental health. And while men are culturally and cultured not to speak a lot of on a lot of issues. They are not culturally oriented to speak about their feelings, their behaviors, and in life. And one of the most challenging moments that most men encounter is to do with their mental health and their health in general when they are confronted with the issues like prostate cancer. Prostate cancer, the little I know about it as a man, it's a disease that attacks an area that men would rather not talk about in their day-to-day life. Two, it also makes them weak, and men are encultured not to be weak. They are encultured to be strong. They are encultured to man up, which are factors that are extremely affected when they find themselves in a situation like where they are confronted by cancer, and more so cancer like prostate cancer, which it attacks an area that would be rather a taboo. Basically, men need to learn to speak out and to know that speaking out is not a weakness. It's rather a strength. It's the only way they can be able to get some help. It's the only way they can help themselves, even they themselves in their lives. I don't know whether I can share some slides here.
Yeah, yes, kindly.
I'm trying to share. Instead, you cannot share, you cannot screen share while the other participant is screen sharing. So, Alec, maybe may pull down there.
Dr. Robert, kindly maybe, can we allow Mr. Gikundi to share? Dr. Robert, as we wait for Dr. Mutengo to allow you to share, we can keep maybe hearing your insights on that, on the same.
Hi, sorry, excuse me. I'm trying to pull it down, but I don't seem to find the icon that shows me where to pull it down from. Can someone help me?
It's the icon on screen share at the bottom.
Thank you so much
At
for
the
that.
center.
Well, we can keep going as we wait for.
Sorry. Okay, yeah. Please carry on as I try to figure out what to do.
Yeah, so
Mr. Gikundi, can you try and share? We
what-
can see if it is possible to share.
what I was saying is that what happens with when men are confronted with a situation like prostate cancer, it weakens them not only physically but psychologically and socially in the community. And in the community, men are not meant to be weak. It makes them vulnerable and helpless and unable to engage in even aspects like sex, which is quite an important part of their life. And their vulnerability is very contradictory to their cultural orientation. As we know, men, not only in this part of the world, but all over the world generally, they are encultured to present themselves as tough and old up things, including old up things that affect their life, like cancer. Somebody may know that they have some pain, and before they take it to the doctor, it takes a long time. They even don't know how to express themselves when they go to the doctor, because expressing themselves, they are not man enough. They are not manning up as they are culturally expected to man up. Culturally, there is a lot of pressure on men also to be unwavering. And when they are affected by a situation like cancer, then they find themselves having to waver. They find themselves being financially weak, which is an aspect that they will not be able to sustain their families. And on top of that, men have they also have a higher genetic predisposition to mental health issues, and some of those mental health issues may be emanating from a situation like prostate cancer and the other forms of illnesses and sicknesses. And in life, generally, you find that men do get predisposed to areas or issues that predispose them to trauma, predispose them to danger, and when they get psychologically affected, then in the midst of not being able to speak out, not being able to express their feelings, not being able to share their challenges, and then they even die much earlier in life. They even die much earlier in life. I was looking at some statistics about between men and women in the United States, and as many as 4 times men die of suicide due to bottling up their issues, due to not knowing how to express themselves and confront their challenges, particularly health challenges. And as many as 4 times men die of suicide. And I'm sure the situation, if we get a scientific analysis and evaluation of the situation in our localities here, the situation may not be any different. Too many men feel they are under a lot of pressure to keep quiet about their mental health and even their physical health. And their physical health is something that they should be able to address with a physician quite comfortably, but they don't. Many of the men have worked in with a situation. They have learned to believe that they can work through issues just in their silence, and they can cope with that in their silence. In my practice,
Sorry, Mr. Gikundi, just to maybe interject there, concerning the health with the men in regards to prostate. So do you think they are given enough support to seek treatment? And what ways do you think we can support them when it comes to seeking now treatment, or even going for screening itself?
I wouldn't want to say that the men are not given enough support. Men are given enough, as much support, but they don't partake that support because they themselves, they have their own way of blocking the help by believing
so it
that
is for the men to open up.
Yeah, believing that they can
open up, right?
Yeah.
Now they are given support, so now it is up to the men to open up and accept the support. That is what you're saying?
Certainly.
Oh, all right, thank you so much. Maybe Dr. Robert, you can take us back to the screening. Dr. can you hear me? As we wait for, oh yeah, there you are. Can you maybe proceed with the screening of the disease so that we can understand that part as well?
Okay, so screening of the prostate cancer is majorly by monitoring, rather by checking the PSA. So the American Urology Association recommends that men above 55 years or 50 to 55 years should be doing PSA testing every once in 1 year. Rather, let me say it this way, that we should be screening after 55 years yearly, do a PSA test and see how the PSA shows. And also men who have a high risk, who are at a high risk, like those who have family members, their father or their brother have had prostate cancer, for those, they should do screening at the age of 40. At the age of 40 years, they should do screening. And for men less than 40 years, screening is not recommended. That is just as far as screening is concerned.
Okay, thank you so much. Maybe just to take it to Dr. Mutiso. Dr. Mutiso, we do understand some of these things come with effects on the daily life of the patient. Maybe can you let us know how prostate cancer can affect the daily life of a patient from a urological point of view?
Yes, in terms of daily life, as we said, for those ones who have come, those ones who are in early stages, usually they are asymptomatic. These ones we get to catch the disease through a screening process, as has been described. But for those who are symptomatic, the quality of life of the patient is actually affected very much because number one is their ability to pass urine well. This is they're almost always obstructed, and that means they keep on getting a lot of infections and their daily life is affected. For those who also have spread of the disease, there will be issues of now bone pain, loss of weight, and loss of, especially since the prostate is important in sexual function, there will be loss of libido and erectile dysfunction also. So as you can see, these are patients who are really, really affected, and that's why even in their management, we have to come together a panel of experts, the urologists, the psychologists, the cancer specialists, and all these are geared towards assisting the patient to have at least a better quality of life with some form of management. Yes.
Thank you. Thank you so much for that. Maybe just to a question for Dr. Mutengo as well. Yeah, but just before that, just to let our audiences know to keep sending in their questions, and of course, our specialists will be able to give you comprehensive and clear answers, hopefully satisfactory ones for you. So, Dr. Mutengo, a question for you: what are the treatment options that are available for a prostate cancer patient?
Okay, so thank you so much for the question. So prostate cancer, usually there are 3 or 4 modalities of treatment that usually engage these patients in. We put them on hormonal therapy, first of all, depending on their risk. We usually stratify them, either high risk patient or low risk patient. And the hormonal therapy is given depending on their risk. If low risk patient, hormonal therapy is done for 6 months up to about 1 year, beyond which there's no benefit. And for high risk patients, we do hormonal therapy for a minimum of 2 years, in a maximum of 3 years. So then after, as the patient takes hormonal therapy, we also do radiation, whereby we treat them using radiotherapy to the primary disease, that is the prostate itself. We target it with radiation to be able to kill or suppress the cancer cells. Then depending if the patient has had metastatic disease where other organs of the body are involved, then at that point we may need to do chemotherapy. And also, as we keep monitoring the patients, if we see that they are developing resistance to the treatment, is how we can move around with the hormonal therapy, manipulate a few things, and be able to get good control of the disease. So basically, those are the interventions that we do for patients with prostate cancer.
Thank you so much for that. Dr. Mutiso, I'm sure with all these treatments, some of them have side effects that majorly affect the urological part of the patient. Maybe can you kindly elaborate to us the effects the treatment has, and are there ways to manage those effects, or are there even ways to prevent them?
Yes, as with all medication, all treatment modalities, there will be side effects. For the radiotherapy, of course, it is killing, it's usually localized, but also it can affect organs around, the prostate itself or the nerves. And should such be affected, we can have erectile dysfunction, we can have urinary issues, not clearing the bladder well, and also can affect the organs around it, like the rectum and the bladder. So for the hormonal therapy also, because we are in hormonal therapy, we are trying to suppress the main hormone, which is testosterone, which is the main hormone that is suppressed to help suppress the prostate cancer cells. This will also affect the general well-being of the patient, because the testosterone will be suppressed, and there will be issues that also will affect, like libido, things like there'll be general weakness. Patient doesn't have the normal vigor in life. But now there are those drugs which are used also to try to assist in that. So the main usually are affecting the organs around, and also affecting the general status of the patient due to the suppression of testosterone. Yes.
Okay, thank you so much. Just to you again, just Dr. Mutiso, maybe you told us that at the beginning of prostate cancer, the patient has is asymptomatic, they don't show any signs. Later on in the stages of the prostate cancer, are there signs that maybe a patient ignores and they might be very important to have checked?
Yes, one of the main ones is usually low back pain because of spread to that area. That's usually one of the first places the cancer spreads to, the spinal, the vertebral bones, that's it, the backbone. And since these are patients also who are elderly, they will always ignore it as something that is just a back pain that is there, comes and goes, and as it becomes persistent. So it is always advised, if it is a back pain that is not responding well to normal treatment, because back pain is also common, then they should have it analyzed by scanning, a CT scan or an MRI. The other issue is also when they have, when it spreads to the nerves and all that, they will have some issues like the erectile dysfunction. They might have issues of urinary problems, which they might ignore, thinking that is normal with their age. But it's always good at that age, as it has been described, always screening from the age of 55 should be done so as to ensure that we don't miss anything. Yes.
Okay, thank you so much for that. So maybe a question for Mr. Gikundi, because we've seen this patient maybe they have decided they have, yes, the cancer and they are willing to move with the treatment, they are in acceptance, but there is a support system behind that person. Sometimes people don't know how to support a cancer patient. Can you maybe kindly let us know how best we can support a patient, especially being a male partner?
Yeah. Having an erectile dysfunction can be one of the most challenging factors in a man's life, and the only best support that a member of the family and a spouse, for that matter, can give is to be able to listen to the man, to be able to identify with their challenges, because they are going through a challenging period in their life. And if you cannot identify with the challenge that they are going through, they themselves find it very difficult to even cope. They may engage in coping mechanisms that are dysfunctional or are going to worsen the situation altogether. So listening to them, supporting them, having moments to understand the challenge that they are going through can make a lot of difference. And it can also ensure that they follow up on their medication, they follow up on treatment, and at the same time they also can acknowledge the fact that they may never go back to the situation that the position they were, both sexually and physically, and even in other activities in life. They may never go back to that position. And also they need to start acknowledging the fact that the age comes with the many other challenges besides the sicknesses. It comes with many other challenges, and it's not only the man who is affected, but even the wife could be affected and going through our own set of challenges. It's important to share that.
Thank you so much, Mr. Gikundi, for that. Dr. Mutengo, I understand that there are some support system that is offered. Probably, can you maybe let us know about the support that is offered from the HCG Cancer Center?
Yeah, thank you, Lucy. Let me just comment on the question you asked me earlier about the treatment options that is given to this patient with prostate. You'll realize that I did not mention surgery as part of the because usually surgery is not what we want to do initially for these patients, and it is reserved for recurrency. If the patient after treatment again has a disease right at the prostate after radiotherapy, and for such patients that we cannot irradiate again, then we opt for surgery. So it is some kind of plan B or some salvage kind of an option that we adapt when the patient gets recurrency to the prostate itself, because radiotherapy has been shown to be as effective as surgery. So there's no need really of subjecting the patient to surgery, considering all the complications that may arise. And also afterwards, the patients usually tend to leak urine and smell urine all over, and also sometimes have problem with erections. Even though radiation does the same, but the risk of surgery is eliminated when the person is taken for radiotherapy. So that is why we usually recommend radiotherapy first of all, and hormonal therapy, with surgery being the really last option when the doctor is stuck what next to do to the patient. So here at Cancer Care Kenya, we have a support group that is called Faraja. Usually we enroll all our patients to Faraja. They get to meet other patients who have survived similar disease or who are undergoing treatment, and they talk and share experiences and able to learn from one another how to cope up with the side effects of treatment that are usually quite toxic. And also Faraja provides financial support to these patients. Some of them cannot afford the quite expensive treatment. The hormonal therapy is quite expensive, and radiation therapy techniques are also quite expensive, and many of them who don't have insurance cannot afford. So Faraja came up to be able to support these patients, both financially, socially, emotionally. There are counselors who counsel the patients as often as the doctor thinks counseling is needed, and all this is offered for free. So as many as our patients are willing, usually they get enrolled. There's no membership fee. Everything is done for free.
Thank you so much. Thank you so much. Maybe there's something very crucial that I have left out, and I would direct it to you, Dr. Mutiso. Can you let us know the difference when it comes to enlarged prostate, so that to create an understanding and the difference between the both?
Yes, an enlarged prostate, what we call benign prostate hyperplasia, that is BPH. You hear the word BPH. This is for every single man after the age of 40, 45, the prostate will increase in size. That's for everyone. So that is what we call hyperplasia. It increases in size and in number of tissues. So for every decade, there will be a certain amount of increase in size, usually around 5 to 10 milligrams. So this is a process that goes on for every month. And for some men, the enlargement will cause obstruction of urine. Those are the ones now we get to give medication or do surgery to remove a part of the prostate, the one which is blocking. And the reason it's not cancerous, that's why it's called benign. It's not cancerous. The difference now in prostate cancer, as we've been told, is that it's different abnormal cells and abnormal tissues which occur and start invading the surrounding tissues. They might present clinically in the same way, obstruction. But for cancer now, you'll have to check the risk factors of the patients so as to assess how to screen them. But benign prostate hyperplasia, that enlargement is there for all men, but not all men will have symptoms. Yes.
All right, thank you so much for that. It is so enlightening. Just to let our audience know to keep bringing those questions in, we have specialists that are going to give you answers and give a better understanding of whatever questions, inquiry you have. So we have an inquiry. A member of the audience would like to know what the Gleason score of the prostate cancer is, and elaboration on that as well. Dr. Mutengo, maybe can you kindly address that?
Thank you. So the Gleason score is a score that we use to categorize the patients to be able to tell their risk stratification and the aggressiveness of the disease. It is usually done by the pathologist. Once the urologist gets the specimen, the biopsy, they deliver it to the pathologist to analyze it. Then the pathologist will give us a report telling us the level or the degree of cell differentiation. Now, I don't know how to say that better, but it just tells us how abnormal the cells are. Cells that look closer to normal cells are a bit better than those that look far from normal cells. You understand? Cancer cells, the more they differentiate, meaning the more they mutate, the more they become abnormal, the more they look so different from the normal cells. Such a tumor is quite aggressive. And if the score is about, okay, we score it from usually from 6 to 10. If the score is lower, it means the cancer is not very aggressive. A score of 8 or 9 is quite an aggressive disease because it's telling the doctor that the cancer, the cells have really differentiated, have really changed and transformed and become very abnormal. And they look so abnormal compared to the normal cells. So it's basically a score that we use to be able to predict outcome and the aggressiveness of the disease.
Would that be a factor to determine the mode of treatment for the disease?
Yes, it is. Like I mentioned earlier, once I get a higher person score, I know the patient is a high risk patient. So for that patient, they will be put on hormonal therapy for a minimum of 2 years, you see. And for a person who has a lower Gleason score, it's telling me that this is a low risk patient and I do not need to be very aggressive. The hormonal therapy goes for 6 months, thereabout.
Okay, thank you so much for that. Maybe Mr. Gikundi, I could direct a question to you because there are these people who are supporting a cancer patient, be it family or friends, they have a lot on their plate as well. I'm sure they also feel very overwhelmed and they are also in distress of some kind. Maybe can you let us know, is there maybe therapy options for support systems? Mr. Gikundi, can you hear me?
Yes.
Okay.
Yes, I can hear you. The caregivers, and this includes even the doctors, like my 2 colleagues who are with us here. They also require to be taken care of or to take care of their lives. And there are various categories of caregivers or support systems from spouse and the family to healthcare providers to psychologists. And all those, they also need this a support system as they go through those challenges. In KAPC, where I practice and I've practiced it over the years, we do conduct specific support groups for target groups. There are those people who may be struggling with the relatives and the friends who have suffered as a particular kind of ailment. Maybe they have a mental breakdown. Maybe they have a child who has a disability. They have gotten a child who has a disability. Maybe they have a spouse who has just found that they are suffering from various types of cancer, including prostate cancer, and they can come together, discuss, support each other, with a therapist who can be able to facilitate. The therapist may not give them guidance, so to speak, because a lot of times they have a lot of knowledge when they are confronted with those kind of situations. They have a lot of knowledge around that. The challenge that they are encountering is how to cope and cope productively. And they can benefit a lot in a group setting, particularly a small group where they can go able to be vulnerable.
Mr. Gikundi, you're breaking. I don't know if you can hear us clearly, but there's a break in your voice. Hello, Mr. Gikundi. I don't know if you can hear us, but there's I think it's a network issue. All right, okay. As we wait for Mr. Gikundi to join us back in, maybe I'd like to ask Dr. Mutiso about the aftercare for those patients that have been diagnosed with cancer. They've gone through treatment. What aftercare is available for them in terms of medical aftercare?
Yes, since cancer is something that cancer is what we call is not we are trying to attain a cure for the ones who are in early stage, but since cancer is something that will be there, we usually as urologists work very closely with our psychologists, our counselors, who give the support, long-term support for the patient and the family. And we usually come in terms of medication is mostly to deal with any of the side effects that might have come from the medication, the treatment, either the radiotherapy or any form of surgery that is done. So it is usually a long-term thing that the main part is the psychotherapy for the patient and the family, and also for any side effects that we handle as they arise. Yes.
Okay, thank you so much. I'd like to ask Dr. Mutengo, as we wait for Mr. Elias, what is the 5-year survival rate of different stages of prostate cancer?
Okay, so part of the risk stratification that usually we come up with before we adapt on any treatment intervention is the life expectancy. You look at the age of the patient, you look at their, if they have any other medical conditions like they're diabetic or hypertensive, or they have kidney disease, or for any other reasons that affect their health. So usually we're able to tell that this patient will live for 2 years or 3 years or 5 years, depending on those factors. If you get a patient who is 88 years and is diabetic and has a prostate, this guy is likely to live for 3 years, or, you know, so you don't want to be very aggressive in the treatment, because also that will affect their daily life. And for a younger patient of 55 years with a prostate cancer, I'm expecting him to live for more than 10 years. So again, I'll be very aggressive in my intervention in this guy so as to cure him. So it really depends on several factors: the age, other medical conditions that are existing in this person, any long-term medications they are taking, and such like factors.
All right, there is a connection between breast cancer and prostate cancer in some way. Can you maybe shed some light on that? Let us know what is the connection between the two, and now how can we improve our chances of not having prostate cancer from maybe breast cancer or vice versa?
Yes, there actually is a connection. Breast cancer is usually associated with the BRCA gene mutation. There's usually BRCA1 and BRCA2. These are genes that when they're mutated, the person is at risk for developing cancer. Now, for the females, if they have a BRCA mutation, they have up to 80% risk of developing breast cancer. And for the males who have the same gene mutated, they have up to 40% risk of developing prostate cancer. So it is true that there is a relationship because the genes are really much the same.
Okay, thank you so much for that. Mr. Gikundi, I can see you're back. Thank you so much for rejoining us. So can you just proceed and enlighten us as you were before on the support system?
Yeah, I was saying that there are support groups. Support groups do exist. And in KAPC, we've run support groups over the years on various issues, including for relatives who are supporting patients that are going through a particular condition. One of the areas that we have supported for many years is in HIV/AIDS, as you know. Relatives and the families who have children with various types of disabilities, and NCDs or non-communicable diseases, where cancer falls very much so, is one of the areas that we've conducted the support groups for relatives. And we also need the support groups for even other professionals who are working with this kind of patients. This kind of patients, they present themselves with sometimes a lot of anger, frustration, depressive moods, and all kinds of situations that ends up also affecting even the professionals that are helping them, including counselors and the clinicians. In those support groups, if well utilized, even the patient themselves can benefit a lot, because when there is trust and confidence built in the group and the patient feels that they are understood, they will be able to allow themselves to be vulnerable, to be weak, and to be supported. They will also be able to understand the struggles that their loved ones are going through, that the struggles that their loved ones are also going through a patch of struggle in understanding how they can support them, and they can share in that kind of a support group.
Thank you, Mr. Gikundi, for that. Now I'd like to ask Dr. Mutiso, do you find that recently that men are open to seeking treatment, to seeking help than before? The same to Mr. Gikundi. Are men open to seeking therapy at this age more than they did before, or are we still a long way to get there?
Well, on my part, I see due to the awareness, due to the awareness that has been there in our media, and in the availability these days of at least there is some help someone can get. Unlike before, when it was more or less a hopeless situation, there are many modalities now with more clinicians who are now specialized, like oncologists, therapists. So we find patients now are more willing. I find them more willing to open up, to be open to the modalities of treatment. And I can say, as compared to before, we are moving somewhere. We really want to get better than that, but it's an encouraging move that patients are now more open and their families are more open to the mode of treatment that we have now.
Thank you, Mr. Gikundi. Are they more open to therapy?
There are more men who are open to therapy. If we just give some basic statistics in our center, in the 90s, we would only have a current portfolio of just about 2% who are men. And a number of those would be dragged into therapy by their spouses, particularly in the family therapy situations or couple counseling situations. Today, we have a case scenario where you have almost 10% in terms of statistics, and 10% is quite an improvement given our history. And as that also reflects in terms of their health-seeking behaviors, particularly to go for checkups for potential ailments and sicknesses that they may be encountering. I personally would find it much easier to go to seek a treatment from a doctor or to check up, to conduct a checkup than I could have been in 5-10 years ago. That's improving.
Oh, great. So during the opening remarks, Dr. Mutengo, you had shared that men of African descent are more affected by prostate cancer. What could be the cause of this? Would it be diet or just environmental factor?
Well, the exact explanation has not been established yet, but it has been observed that men of African descent have an aggressive disease and are more prone to developing prostate cancer. In the US, Blacks are leading in terms of prostate cancer incidence and also the aggressiveness of the disease. So usually almost all of the guidelines and the research that we use world over are US based. So I think that is how we come up with this fact that Africans and Blacks have the aggressive type of disease and usually tend to have more incidence of the disease compared to Caucasians.
All right, thank you so much. Dr. Mutiso, we have a question that is recurrent from our audience. Prostate cancer is a huge cause of ED in men. So maybe do we have treatment for that as an aftercare? And what kind of treatment is available also for that?
Yes, for the rectal dysfunction as a complication, we have treatment modalities currently for erectile dysfunction. In terms of medication, there are medications that we have that assist in the rectal dysfunction, both oral tablets and there are also injectables and also those ones which can be inserted into the urethra. So there is a range of what we can call a pharmacological range of drugs that we can use for the patient. And also, because these patients are classified in erectile dysfunction, they are classified as having an organ issue because they already, either the disease itself, cancer, has affected their nerves or the treatment modality. So for them, we usually go straight to the medication that most of them, we have around 70 to 80% positive response.
All right, thank you so much. Just to clarify with Mr. Gikundi, when it comes to such effects such as the erectile dysfunction, do we have therapy for couples that come in search of the relief from distress that is related to such?
We do. Though in a lot of case scenarios, you find it's one partner who seeks therapy first, then brings along the other partner. But we do have therapists who even specialize on areas to do with the sexuality, and also support for that kind of clients.
Do we find that women are the ones who bring in the men for therapy?
Mostly.
And is it advisable for the woman to bring in the man, because also for the ego of the man? What do you advise when it comes to that?
Mostly it's women who bring their men to therapy, a majority. It's very rare that you find a man is the one who is seeking therapy first and bringing the wife. We would encourage if the man can find it fitting to also come along. It works much better than just attending to the woman alone. So we would still encourage them to bring them along, and but the therapist needed to strike a balance to ensure that the man does not feel like there is a connivance between the wife and as therapists. They should be able to communicate very well and effectively to assure the man that he has also as an equal chance in the therapy space as the wife.
So how should the wife approach it in a manner that it won't be a trigger for the partner? Like how should she approach the partner for therapy in a manner that won't be triggering for them?
Basically, there isn't a way that I can tell you this is the way, because you know your spouse, and that's where I approach it from. I will approach it from the fact that you know your spouse, your husband, and the ways in which you can communicate with him, for him to feel that you respect his position as well, because there is that ego aspect of the man as well, and you need to approach him and request him to accompany you to therapy from a willing point of view, a willingness. Even for him to go and seek medical treatment, because sometimes you find that the wife is concerned because she knows that the husband is suffering from a particular physical condition, but they are not even seeking physical treatment. For him to do that, they need to feel respected. They need to feel that you are doing it from a point of concern and not belittling them.
Yes, thank you. Thank you so much, Mr. Gikundi. So thank you. I want to thank our panel so much for being with us. Maybe can we have a few remarks from Dr. Mutiso as we intend to close?
Yes, thank you so much for organizing this webinar. What I'll just say is that we have come a very long way in the treatment of prostate cancer in particular, and generally for treatment of cancer. So I'd like to urge all those who are present in this webinar that please go for checkup or screening as per the guidelines that we have been given. And do not feel that this is a lost case. There's a lot that can be done presently, and in the future, definitely things we will get better. So I will encourage for regular checkup. And once you find that there is an issue of cancer, even if it's not you, please encourage the person to be able to come and seek medical help. As you can see, we are many specialists in different groups that are all geared to assisting that one patient. Thank you.
Thank you so much. Dr. Mutengo, maybe your remarks?
Thank you so much for this webinar. Thanks to all the organizers. So I would want to close by saying that prostate cancer is treatable. Prostate cancer is curable. It is important that men take care of their health and their prostates. Regular checkups have been shown to improve the outcome of disease, because most of the patients that we get here that have early disease are those that have had the habit of checking their prostate regularly. So for them, we're able to cure them. I've seen a few of them that are cancer-free, and they are okay up to date. So this is curable. It is a battle that we can all fight and win if we take care of our health regularly. Thank you.
Thank you, Mr. Gikundi.
Yeah, I would want to say that the future looks bright, and to my men folk, it's okay to be vulnerable, it's okay to be weak, and to be transparent. It does not make you any less of a man. And we need to speak out to be able to get help. And we should be take the lead in terms of the health-seeking behavior as well. It's not a woman's space; it's a joint space.
Right. Thank you so much, our panelists. I'd like to give a special thank you to you, Dr. Mutiso, Dr. Mutengo, and Mr. Gikundi for these very, very informative sessions. Also to our audiences, if you joined in late or if you'd like to have a review of this, just to let you know that a recorded version is available on all our social media platforms. That is My Health Africa on both Facebook and Instagram. Also, just to let you know, should you need to book an appointment with us to see Dr. Mutiso, to see an oncologist, Dr. Mutengo, or any other at the HCG Cancer Center, and to have a session or more with a counselor at the KMPC, we are here to book for you. Can you reach us on 0711 082 072? Both on call and on WhatsApp. Yes, we are available on WhatsApp as well. You can as well draft an email to us at support@myhealthafrica.com. I hope this was as informative to you as it was to me. That's it for now. We wish everybody a lovely evening. Thank you so much.
Thank you.
Asante.
Thank you too, Lucy.